What if I told you a patient came in with chest pain and pulmonary edema, but no EKG had been done? This is a story of a missed STEMI, one that was only uncovered because of a POCUS scan. Let's walk through how bedside ultrasound helped change the course of this patient's care. I'm about to show you some images of a 78-year-old woman with a history of hypertension who presented to the emergency department with epigastric pain. Like many abdominal pain patients, a CBC, Chem14, and lipase were ordered from triage, all of which returned normal. She was eventually roomed and seen by the resident, who noted that in addition to her abdominal discomfort, she had also had chest pain. These symptoms had resolved, and she had no specific complaints at that time. But on exam, he noted bilateral crackles and that the patient required supplemental oxygen with an oxygen saturation of 88% on room air. The resident presented the case to me. Given the crackles and hypoxia, I was concerned about new onset heart failure. I added a BNP and troponin to her labs and grabbed my POCUS machine, but something just wasn't adding up. So the patient confirmed her symptoms. She was clearly tachypnic and her skin was dry, and there was no leg swelling, and she really didn't appear volume overloaded. So here's the right anterior section of her lungs, and you'll see that there are very confluent B lines. Basically, every single segment of her lung is just filled with B line. Here's the same thing laterally, where every single one of the spaces has a significant amount of B lines. You saw at the end that there's no pleural effusion. On the left side of her lungs, there were more and more B lines. This bilaterality confirmed that this was pulmonary edema. Here's the base of her left lung where she had a small pleural effusion and more B profile. So at this point, I've diagnosed pulmonary edema, but at the same time, she was not clinically volume overloaded. So what could have possibly caused her to be in pulmonary edema and not volume overloaded? Certainly a myocardial infarction or a heart attack could do that. So next, I was going to look at the heart to see if I can find an answer, both as to if this is cardiogenic pulmonary edema, but in addition to that, what I also saw instantly changed her management. I first looked at the parasternal long axis view, and it's a little off-center, but what you can first notice is that this entire anterior and lateral section of the left ventricle was not moving at all, while the septum down here and some of the inferior portion was moving really nicely. This is a short axis view where you can see the anterior part of the lung essentially akinetic, and the septal, inferior, lateral, and posterior portions of the heart were moving pretty well. So there's clearly some regional wall motion abnormality where this section, which is the anterior part of the heart, was completely akinetic, not moving at all. The apical four-chamber view shows something similar. The septum is moving nicely, but the apex up here and some of the lateral wall covering the LAD was completely akinetic and not moving at all. And for completion, here is the IVC, which was distended and did not change at all with respiration. So with no prior cardiac history, this really raised my alarm for an acute coronary syndrome and possibly even a STEMI. So at this point, I did what most of us assume is already done in the ED. I looked for the EKG, which I assumed had already been seen by an attending physician and been called not a STEMI. But there was none. No EKG had been done at all. I immediately ordered one and called the EKG tech to perform it emergently. Here was the EKG that shows anterior ST elevations, significant ST elevations from V1 all the way through V4 without any significant reciprocal changes, but some flattened T waves in the lateral leads. This EKG confirmed a STEMI. She was taken to the cath lab, found to have a 100% occluded LAD, received 3 stents, and made a full recovery. Yes, she should have had an EKG earlier, but what changed this patient's trajectory was the point-of-care ultrasound. It was the ultrasound that prompted the EKG and got her to definitive care. And this is why we scan, because Sometimes, even in the best functioning system, POCUS can be what makes the diagnosis when no one else has. And this truly changed the trajectory of this patient's care. And that's why we're in medicine, to help patients learn point-of-care ultrasound, and you too can make these diagnoses. I'm Josh Gutman with Peachtree POCUS, and I'll see you on the next video.